Welcome to Joint Effort with Des Moines orthopedic surgeons. This podcast covers the pain and injuries that are associated with muscles, ligaments, and joints.
Welcome to Joint Effort. I'm your host, Dr. Jason Sullivan, fellowship trained in sports medicine. Today we have esteemed guest, Dr. Barron Bremner. Dr. Bremner has a practice that focuses on both sports injuries, which he covers Johnson High School and Grandview. Also has a focus on total joint arthroplasty. And tonight we're going to talk specifically about something that's very close to his practice and what he specializes in, what's called anterior total hip replacement. Welcome aboard.
Thank you, Jason. Just want to say I've been listening to your podcast for a long time, and I really enjoy it.
Well, I wanted to open with I'm the second best host on this for Joint Effort.
No, that's not true.
Because when I watch yours, I think you do a better job than me. But regardless, thank you for coming on tonight.
Thank you.
We appreciate it very much. So, Bremner, give me a little background here. I know a lot about you, but our audience doesn't. So I know that you're incredibly athletic and you come from an athletic background. So tell me about how your father's kind of athletic pursuits influenced you to become what you are today.
I do have a lot of athletic connections in my background, mainly around my father, who grew up in Iowa Falls and was a multi-sport athlete and played football and wrestled at University of Iowa back in the 50s, and was fortunate enough to be on some of Forrest Evashevsky's teams, and really he was
those national title teams?
I think two of them were Rose Bowl teams. I don't know if they were national championship teams, but yeah, in 56
What about wrestling?
and 7. He was Big Ten champ at heavyweight.
Unreal.
And actually was invited to the Olympics, but didn't get to go because Evashevsky wouldn't let him out of practice. And he wasn't a starter for the football team, but he was on the second team.
So how in the world do you succeed in your dad's eyes growing up as a wrestler when he did all the
He was very he was not pushy at all, and gave me enough instruction. And I remember wrestling my mom when I was my mom was 104 pounds, 5'4", and I was, like in 7th grade, 8th grade, I would wrestle her in the living room, and that's then I wrestled my older brother a lot, and there was a lot of shenanigans going on there.
You went on to wrestle and play football yourself then?
Yeah, in high school, like a lot of Iowa kids in small towns, like in Mount Vernon, we like to play 4 sports and have a great time. And then in college, my real love was football, but I also wrestled in college too. So that was a good time at Cornell College in Mount Vernon. I didn't get too far away from home.
Okay.
So.
And then from college, you somehow figured out it's time to go to med school.
Yeah, I think I probably would have been, my dad was a coach and college athletic director and like a VP at Cornell, and he went back and forth co and Cornell. And so I probably would have been like a football coach or a teacher, but I really enjoyed science too, and I enjoyed construction, which I did construction from a young age. So I just think kind of orthopedics is kind of an amalgam of everything I did, all the years of construction, the years of science training. I just really enjoyed all that, and this is a way to put it all together.
Was your dad your wrestling coach?
It was not mine.
Okay.
No. By that time, he was athletic director, and then so I had Steve DeVries for my wrestling coach at Cornell.
Okay, all right. So you ended up at DMU for med school.
Yes.
And then on to Mayo.
Yes. Yeah.
Tell me a little bit about Mayo. Everyone's heard, it's probably the foremost medical institution in this country.
Yeah.
When you think medicine, you think Mayo. Tell me about your time there for 5 years.
Oh, it was amazing. You see so much different pathology. By that I mean like different kinds of injuries. The 30 surgeons there are leaders in thought in all their different disciplines, and so you might do 3 months with somebody who's doing amazing transplants of muscles in the upper arm for a bad brachial plexus injury, and then I did a lot of joint replacements there because they were for about 10 years when I was kind of in the middle of that, they were number 1 in the country with the U.S. News and World Report for orthopedics, and so it was great to be there. I learned a lot. I really owe a lot to Mayo Clinic for my background and training.
Do they have an airport in Rochester for all the VIPs that fly in there?
They do have a little private airport. I remember when, kind of right at the beginning of my tenure there, which would be back in 2002, they were still seeing a lot of the Arab world would fly in, and they would, like the princes and sultanates and stuff, would have the whole top floor of St. Mary's Hospital and
really?
Special doctors and everything. I don't know if they do that as much. I think they got a Mayo Clinic over there now, but it was pretty interesting. You see people from all over. You'd see the Bushes. I think some other people that I had care of that I can't give you the names of, but a lot of famous people there. A lot of interesting stuff.
When you were there, did it kind of click that, hey, I would like versatility in my practice, and I want to do a combination of some things that you do currently?
It's kind of weird. I always kind of wanted to come back to Iowa. I always wanted to do everything. Not everything, but most everything. I didn't want to do one thing. I didn't want to just do knee and hip replacements. I didn't want to just do hand surgery. So I really kept track of all the different things I did up there, kept little note cards on everything. So then because I knew I was going to go into private practice and not be like an academic and just, do one particular thing.
Okay, fair enough. So, I think what some people may not realize is that the Des Moines medical community is pretty amazing, I think.
I agree.
We have experts in every, field that you could imagine. And so people like yourself go and get that training at Mayo, and then you bring that same level of care to Des Moines, which I think is important for everyone to realize. And so from your time at Mayo and all those experiences that you drew upon, you kind of formulated, you came to DMOS thinking I'll do a little bit of everything, and then have slowly kind of honed in on things you really enjoy. Or are you still doing are you doing some hand surgery still?
Yeah, I still do. Basic hand surgery, trigger fingers.
Yeah.
I enjoy that stuff. Trigger
really?
finger,
That's
carpal
great.
tunnel. A lot of wrist fractures. I'm happy to do that stuff. I love it.
And in terms of sports, I know you like working with athletes.
That really keeps my practice interesting. I'm so glad that I work with Grandview University and with Johnston, because I get to see all these kids, and like I said, I almost was a coach or a teacher, so it's really kind of fulfilling to me to talk to them. They keep me young.
What are you doing
somewhat.
at Grandview? Are you on the sidelines football?
We do sideline football coverage. When we're asked to come cover wrestling, we cover that. Every Monday, Nick Honkamp and Nick was interviewed earlier in the session. Every Monday we go to training room there and just kind of help their fantastic athletic training staff diagnose and treat their injuries. And if they need x-rays, we bring them over to clinic and get that done. But a lot of times we can deal with stuff in the training room.
Fantastic. That's awesome. A few other things when I got here that I realized, I know you enjoy biking, and you kind of ran through the 5 different kinds of, you have a fat tire bike, you have a road bike, and the DMOS actually sponsors a bike team, correct?
Yeah, that's right.
A cycling team?
Yeah, it's a really nice team. It's in in Des Moines, mainly central Iowa. It's got a wide variety of people that are in it, everything from really recreational people to super serious racers, all ages. I think it's got the biggest women's group of racers, at least it did a few years ago, even down to juniors for younger kids to train.
Sure. And you're still kind of amateur, but you're riding yourself. You're not racing anymore, but you're...
Yeah, I don't want to give up my amateur status yet, so... No, I don't ride as much as I used to. I used to do triathlons and a lot of bike races. I had a couple hairy bike races in races where, one time one guy dislocated his finger, another time I had road rash all over my body and broke a couple bikes. So I decided that's probably I'm not going to be a pro. So it's probably smart to just ride, and
Absolutely.
play tennis, and that's about it.
I think your practice actually does a nice job of exemplifying your personality. As you said, you like to do a bunch of different things. And the only time I've ever seen someone engineer and steer a drone at their own party was at your 40th birthday party, when I didn't even know what a drone was at that time. But
My future 40th birthday party?
Yeah, I'm sorry. It's coming up. That was your 30th, right?
Yeah, right.
Your 30th. But no, I look up and what is that noise? Oh, Bremner's got a drone up there. You had it following the party and doing all these innovative things.
Yeah.
And so it seems like you like to look into new avenues of doing things differently. And
Yeah, I do
that's
like
kind
to
of a cool
stay up
way to
on that.
film your party.
Yeah, it was.
Anyway, so let's get down to it, because
All
everyone
right.
wants to hear about, what does an anterior total hip mean? So we know a total hip is a replacement of the arthritic hip joint, correct?
Right.
So tell me, when you say anterior total hip, what are we talking about here? Is it a different procedure?
It's mainly the approach to the hip. So
When you say approach, what does that mean?
how you get in to do the work that you need to do.
Okay.
So traditionally, this actually is kind of a traditional approach to the hip joint, although when it was used initially in Europe, it was probably like a 2-foot long incision. It was going in this plane, which is in the front side of your thigh, up near the groin crease. Not really deep in the groin, because that's where the arteries and blood vessels are, but it's a little bit off to the side. But it's not a brand new approach. It used to be used, like I said, for other hip surgeries, trauma, but it was a big extensile surgery before. For hip replacements, kind of originally back in the 50s and 60s, they would do all sorts of different things. Sometimes they would even detach part of the bone to get to the hip, just to get everything out of the way, because you got to get down there somehow, and then they'd have to reattach it, and that was a problem. So there's basically, I'd say now there are 3 basic approaches to the hip replacement. One is coming from the back, and one is from the side.
Back being posterior.
Yeah, from kind of the rear end area.
Front being anterior.
Front being anterior, and then one from the side, straight from the side
Okay.
too. And there are little variations of each, and there are some that have tried 2 little incisions, replicating it. But what I do typically, 99% of the time I do what's called an anterior approach to the hip, which is coming between 2 muscles on the front part of the hip to avoid muscle damage.
Okay. When you trained at Mayo, you obviously learned that there.
So actually, interestingly enough, I was at Mayo from 2002 to 2007, and no one there did anterior approach at all. And they actually, most of them were, we thought we were pretty conservative up there, but by conservative, I don't mean like a step behind. They felt like they were, just didn't want to do anything that was unproven.
Right.
But so at that time, about 2000 or so, MATA was starting to develop this for the U.S. and using a special table, because it's kind of a hard interval to get to. So using a special table and fluoroscopy or x-ray machine during surgery, he was able to get the components in perfect position and not damage any of the muscles. So I did not learn that in residency. What I found out was when I got into practice, I found some deficits with the other approaches, and I found some appealing things with the anterior approach that I wanted to look into. So I had to go actually travel and kind of do a little fellowship on my own. Well, I started out here really close to home, and went to see Jeff Clark first up in Waterloo, because he was doing it. And he was the guy who said, you need to look into this, because I really like it, and I've noticed a big difference in how quickly my patients recover. So he's a friend of mine, and actually my brother-in-law, and so I went to visit him first, and I was like, oh, this can be done.
Right.
I was a little trepidatious about anything new. And then I went to see MATA, who's like, the father of it in the U.S. and out in California.
Okay.
And I also went up to Fargo to see a guy who does a lot of them there. And also, you don't want to just jump into this, so many different courses and cadaver labs and things like that before I even did my first one in 2010.
2010. Okay, so the fact that you graduated residency in 2007, is that what you said?
Yeah.
The fact that Mayo Clinic wasn't doing anteriors at that time, that probably just shows the evolution of how quickly anterior approaches have become popular in the U.S.
I don't know the numbers now, but when I first started doing it, it was about 4%, and last time I checked, it was about 40% of all hip replacements are done anterior approach. Might be even more than that now. No one in my group did it. Hardly anyone in Iowa did it when I started doing it. But since then, a lot of my partners have started doing it too. A lot of my partners still do an amazing job with a posterior approach or a direct lateral approach too. So that's important to keep in mind too.
Ultimately, this always resonated with me whenever you were told that, going through residency, there's so many different ways to do things, correct? Yeah. And with replacement surgery, they always hit home with the fact that component positioning was, took precedence over anything else you did.
Right.
So no matter how you got there, if you didn't put the components in correctly, it didn't matter what you were there to do.
Yeah, you don't really care what the skin incision looks like. You need to make sure the surgery is done correctly. Right. And so I would say my caveat for this talk would be, whoever your surgeon is, if you have a surgeon already, if you like that surgeon and trust them, and they do the approach through a posterior approach, you will have an excellent result. The one thing we know is that hip replacements have one of the highest quality adjusted life years ratings, which means you are going to get a big bang for your buck with a hip replacement. You're going to be miserable beforehand, and you're going to be happy afterwards with low risk of complications. Yeah. And that's with a posterior approach or any other approach. But I think there are some benefits to the anterior approach.
So when you say you'll be miserable beforehand, tell me just briefly, what are signs of arthritis for an individual in their hip? Where do they have pain?
That's a great question. A lot of people, who haven't maybe just are self-referred or walk in off the street and come see me complain of hip pain, and they're actually pointing into their buttock or their low back, because that's kind of think that's the hip region, but a lot of times that's a back problem. Really, the signs of hip arthritis a lot of times will be groin pain. It can be pain from the groin down into the knee, especially the outside of the knee. Stiffness of the hip, like difficulty getting out of your car from the hip, or difficulty putting your shoes and socks on. But really, one of the hallmarks of it is oftentimes groin pain.
Are there conservative things you can do to help them before they need
Yes.
replacement.
Yes. A lot of times people will have already tried a lot of them, which is, trying your Tylenols, trying to stretch, avoiding activities that bother you, trying to leave. When somebody comes into my office and their hip is pretty worn out but not totally destroyed, I will oftentimes recommend they try a cortisone injection.
Okay.
Sometimes you could try a stem cell injection too, which doesn't have as much data behind it, but that might help give some people some relief too before you consider surgery.
Okay. Yeah, we seem like a lot of people are trying those different things, just hoping that this would go away. But what ends up, it seems like arthritis doesn't ever completely go away, and there has to be some genetic component towards why, or environmental component in combination that leads towards a hip replacement. So is there an age that's too young for a hip replacement?
I would say there's not an absolute age, and you were right about the genetic component and things like that. There's a lot of people are just born with this hip there's a clock going because their hip's not quite perfectly built, and there's a clock. It's going to be 55 years when they wear out instead of 85 years. It's just that's the way they are. But as far as age, I've done as young as 27 years old from a post-traumatic, like a car accident type thing. In general, you should wait as long as you can comfortably. What I tell people is, don't ruin your quality of life. You shouldn't, becoming obese because you can't do anything. Let's pull the trigger and fix it, even if you're 45, if that's the case. But if you're reasonably comfortable, the longer you can wait, the less chance there is that you would need to have another revision in the future, which would be, could be more difficult to do. Every time you do any kind of joint replacement surgery a second time, there's more complications associated with it. So ideally, we'd get to somebody who is going to only have that one surgery.
Okay. And is there anything to what you said about being miserable for your hip replacement? Is there anything to the more severe pain you're in, the better result you have after hip replacement versus if you just have some mild pain and you have a hip replacement?
Yeah.
Is there a big difference between those two categories of patients?
Well, yeah, with it's more so with knee replacements even than hips, but anytime if you have, risk factors for not being satisfied with a joint replacement would be things like, maybe number one, a lot of depression and anxiety. Number two, being on some narcotics going into surgery. Number three, younger age, because I think a couple of reasons. They have more pain afterwards, more swelling, and also they're not as satisfied with the surgery because they want to be just perfectly normal. And with a hip more than a knee, you are perfectly normal. But with a knee, it's always an artificial knee. So along with that, the X-rays. If the X-rays are real bad, you're probably going to do better than if your X-rays are kind of not too bad.
So there is something to waiting as long as you can, and then having it be worth it.
Don't be miserable, but also don't think that it's something at a drop of a hat will replace your hip and you'll be great.
So tell me, in your experience, what has the anterior hip done for your patients? What are the advantages that you see?
Well, one of the first things I saw is that people got off crutches a lot quicker. So I was seeing people at 2 weeks who were, I was struggling to ask them to stay on crutches at 2 weeks because they're like, well, I just used them for a day or two.
Why do you want them on crutches still?
I still want them on crutches for 2 weeks because these implants go in really tight into the bone, and we're relying on the bone and implant then to grow together. So it's basically just to remind them that they had a hip replacement to allow the two surfaces to meld together. Now that'll take more like 6 weeks or even longer, but I really think the first 2 weeks are imperative. Also, they're going to feel amazing when they go home, and they might overdo it and then have swelling and, might have some more pain and then call in and say, well, I'm having a lot of pain, and then we get into this whole thing about
So you feel like you're discharging people earlier, maybe, doing an anterior in your mind, or from what you're experiencing?
Actually, our data has shown that, going to the anterior approach is lopped off about a day or 2 day and a half in the hospital. So people have been going home faster. Also, less pain medicines. So before we have to send people home on heavy-duty pain medicines. Now typically we send somebody home on Tylenol and a non-narcotic pain medicine.
Can you send them home the same day?
We do send people home the same day. We'll do that at 7 in the morning or 9 in the morning and send them home by 11 or 2 in the afternoon.
And that's going just as well, spend a night in the hospital?
Yep, no complications, going great.
Awesome. So in addition to, rehab being a little quicker, is there anything intraoperatively that you particularly like about the anterior approach in terms of, the measurements you're taking?
Yeah.
How do you figure these things out?
That's a great question. One of the things I love about the anterior approach is the posterior approach is great. People do well, but I was noticing that I was doing some things with my surgery because I was worried about dislocation. That's the main knock against posterior approach, is about a 1 to 6% risk of dislocation or the ball coming out of the socket. And so there were some things I was doing with the mechanics of the hip to make sure that didn't happen, that maybe didn't optimize the mechanics of the hip for function. And so with the anterior approach, I use an x-ray machine during it, and I can exactly replicate the center of rotation. I can take x-rays while we're working. Some people who don't use the table can actually check leg lengths just by putting their hands on the feet, but I use the table, so I use an x-ray machine to check our leg lengths. I've also done navigation for leg lengths and
so you
for
can
cup
trial your
position.
components, look at your leg length, say, hey, I'm matching things perfectly. And
Yes.
then one of the great dissatisfiers after a hip gone wrong is
leg length
mismatch in
discrepancy,
leg length,
yeah.
right?
So, part of that is part of that's a discussion with the patient ahead of time about what their anatomy is, because sometimes you have no choice but to lengthen a patient. But the X-rays help us quantify exactly where we are. And with the older approaches, or formerly, people would usually kind of have to estimate leg lengths. So here we can really dial it in.
So you get someone through their surgery, and then they recover really quickly and they feel great. Let's say, unfortunately, a 45-year-old has terrible hip arthritis.
Happens all the time.
And you replace their hip. And, 6 months ago, they really enjoyed running a 5K. Can they run again? Traditionally, a total hip is not recommended to run.
Yeah.
Is that still correct?
Well, so this approach doesn't change anything about the bearing surface.
Okay.
The bearing surface is still going to wear out more when you use it more. And so you can run, but you shouldn't run, okay? I have a guy, I told him never to run again, and he's 75, and I heard from somebody else that he's run about 8 to 10 marathons since I did his hip replacement. Yeah.
Do you get x-rays annually on him then?
No, about every 5 years.
Just bury your
actually.
head in the sand. And
He might bury his head in the sand. I told him not to do it.
How old is he?
He's 75. But active guy. I usually tell people that's the one thing I don't want him to do is run. I don't mind if they ski and water ski and weightlift and tennis and everything else they want to do, but I would prefer them not to run, just because the more cycles you do, the quicker it'll wear out.
Can a patient feel totally normal again?
Yes.
Can they actually feel like they never had a hip replacement?
Yes. That's called a forgotten joint. So the rates of that are very high at 1 year, and I found with an anterior hip, it's more like 3 months, 4 months. People are telling me, I cannot believe I waited this long. This is the best thing that ever happened to me. These are my favorite patients by far. I shouldn't say that.
Well,
you're all my favorite patients, but they're my happiest patients. It's my favorite patient interactions, because they are just like, you have saved my life, that sort of thing.
What other restrictions do you put on them besides the running thing? Can you ski? Can you play tennis?
You can play everything. One knock against some approaches were that you can't cross your legs for 6 weeks afterwards, can't bend forward at the waist. We typically don't put those restrictions on most of our anterior approach candidates or patients, because we don't violate the same muscles a lot of times. Okay. So not really a lot of restrictions afterwards, other than I tell people I don't want you lifting a lot of weight for about 6 weeks afterwards.
Yeah. And then at what point can you forget about you did the patient surgery, you see him at a year, you see him at 5 years then?
Yeah.
Is that right? Every 5 years then?
Yeah, I see him every 5 years.
Do you just tell them, hey, remember, come see me in 5 years? How does that work?
We got a little tickler in the system where we can send out a text reminder.
And that's just to radiographically follow the joints?
Yeah, you just want to check for plastic wear or any signs that there's some early failure that we could intervene on early before there's a disaster, So
with the newer plastics and metals we're using, how long in your mind do you expect these a well taken care of anterior hip to last?
Right. Yeah, right. Well taken care of is the key. If you're a manual laborer and really hard on it, it might be less. But I tell people that with the inferior plastics, the worst ones that we used to have, with the old techniques, you could get, 85% would get to 20 years, and some would go to 30 or more years. And so we're for sure going to get more than that. I'll tell people it's about a 90% chance they'll get 20 years out of it, and there's a good chance they'll go to 30 years with it.
Really?
Yeah.
No kidding. That, as you said, most people won't need another revision of
That's our goal.
Yeah. Well, that's fantastic. Do you send any of these patients to physical therapy, or is walking enough for them?
I only send them to therapy. So I think rest is important afterwards. Icing is important afterwards. I don't want to rush people into anything. And I think that some physical therapy can be more goal-oriented. Like, we got this to do today, we got this to do today, you got to take care of this. And I don't want to get them inflamed. So I think that therapy could be really good for them early on, but I'm not there to, watch everyone. So I like to not have them do regular physical therapy for 6 weeks And if they're still limping at 6 weeks, I'll send them to physical therapy. And it's really rare. I'd say 1 in 30 people I send to physical therapy.
So most people don't even need physical therapy after something like this.
Correct.
It's incredible. Well, folks, you've heard from someone who's essentially helped bring this technique to Central Iowa, if not the state itself. And he's, I believe, does the most anteriors in our group. He does it well over 200 a year. Is that correct?
Correct.
Bremner. So this is a fascinating topic. I think you did a fantastic job talking to, telling people what to expect, and very much appreciate you coming on today. We were going to try and get to some more topics, but we're out of time. But thank you so much for being here. And
thank you for having me.
We could talk all day, but
I
don't think, at some point we'd lose our audience.
Another time.
Thanks so much for being here. We appreciate it.